Hello, everyone. Right, so a little disclaimer here where the webinar on Strangles was held last night, but someone who shall remain nameless may have forgotten to click the record button for the first 15 minutes or so on his computer. We have disciplined that person severely, and as such, he's now having to repeat the first 15 minutes to put the video to make the video complete. But I'm sure that you'll barely notice the seam when it changes back to last night's video. So anyway, we're going to talk about strangles. It causes a huge amount of disruption to yards. It can be extremely costly to businesses and to individual horse owners alone, and it's incredibly frustrating in that often how long it takes for an outbreak to be resolved and for yards to be opened back up again. I think the thing to start with, and the reason I've put it in red here, is I've said it's a bacterial infection. And I think that's really important to remember. Being bacterial, it was going to have different properties, and the way it's spread is going to be very different to that of a viral respiratory disease. And I think we'll talk about that a little bit later, just in terms of how that we can use that information to help control the spread of the disease. So it is a bacterial infection. It is Streptococcus subspecies, Streptococcus equi subspecies equi, most commonly just referred to as Strep equi, and it is very common. It's possibly one of the most commonly diagnosed respiratory diseases each year. There are supposed to be sort of over 300 outbreaks reported each year, and that's outbreaks, not individual cases. And I suspect that is also significantly underdiagnosed. I think, as we'll come on to shortly, there are probably cases of strangles that go through yards where people don't even necessarily realise that that's what's happened. It is unique to horses, and the immunity that they will get from having been exposed to the disease isn't lifelong. It does wane with time. We don't know exactly how long that takes, but it does mean that horses that have been infected with strangles once can potentially be infected again. Fortunately, even though it's a very emotive topic and one that causes a lot of let's put it, excitement in the equine population, thankfully the fatality rates are pretty low. They vary between 1 and 10%. I would say that 10% is a high figure there. And I suspect that if you're getting to a 10% mortality rate, it's because of the population of horses that you've got on that yard. And I would expect it would be, lots and lots of very young stock. As they'll be the most susceptible to it, being sort of naive, having never been exposed to it before. The mortality rate is relatively low, but the morbidity rate, the number of horses that will get the disease, is significantly higher, and that's because it's so contagious. And I guess the question is, why is strangles such an issue? And it all comes down to the fact that the bacteria has this excellent ability to survive and spread from horses that aren't showing any clinical signs. And we'll come on to that a little bit later when we start talking about carrier status. But that's the thing to remember, that actually there is maybe a greater risk from these horses that aren't showing any clinical signs than those where we've got a known outbreak and we can control it a little bit more easily. So, unfortunately, I wonder if I can put that somewhere else. There we go. What clinical signs does a horse with strangles show? And you probably don't need me to read all of these out to you, but pyrexia, or a fever, anything over 38.5 degrees, I think we're starting to pay attention to. And I want you to remember that figure, because that temperature is going to be an exceptionally useful tool for monitoring potential outbreaks or cases that in an outbreak later on. So, yeah, 38.5 degrees centigrade. Hopefully, you've all got thermometer on your yard, well, in your own first aid kit. And hopefully you've all got horses that will allow you to take their temperature. I know that's not always the case. So other signs that they may show, well, we're all familiar with nasal discharge and abscesses. And if this were the live version, we could have a show of hands to see what signs people think that they associate with strangles. And actually, I think the next slide in a second is going to show you actually that we need to be quite careful with that assumption. So we may have swollen glands under the jaw. They may turn into abscesses that burst out either under the jaw, behind the jaw, around the base of the ears. Some horses will cough, and you'll see some horses that have a clear difficulty in eating and breathing, and that's where the term strangles comes from. It's not a brilliant name for the disease, but it when you get really severe cases and you get abscesses that become so big that they start to constrict the airways, then yes, I suppose the name strangles is quite fitting. And then some horses will also present with things like conjunctivitis as well. But the next slide, there we go. I think this is an interesting slide, and I need to give credit to the people that this isn't my slide, which I will do in written form at the end. It's a graph that works in two ways, and just to take, for example, the most commonly presenting clinical sign is a nasal discharge. Okay, and if you then look at the graph above, you can see that actually 161 cases were presented, and this is in a 1 year period. 161 cases presented with nasal discharge. But of that, only 30 of those cases had just a nasal discharge. So we can see that nasal discharge is the most common presentation, but that may be all that you see. And I think that's really worrying and concerning. I mean, how commonly do I hear about cases where I'm on a yard and they said, oh yeah, there was a bit of a cold that swept through the yard, and you just think, well, alarm bells are ringing, because there is every possibility that was something more sinister than people potentially realize. But then there are other combinations, and you can see that pyrexia was noted in 106 cases, but then actually pyrexia and a nasal discharge seen in 26 horses. So the interesting point, and the reason I wanted to include this here, was that the abscesses that we perhaps most commonly associate with strangles presented in 51 cases. Now that's sort of a third of the number that presented with a nasal discharge. And it could be that we have strangles go through a yard without necessarily being fully aware of that being the case, which is again why I think partly our number of 300 outbreaks per year is probably an underdiagnosis or an underestimate of what we actually see. So here are some pictures of what we might see. And yes, it's an old picture at the top left, but you can see the thick purulent nasal discharge, and that would be relatively common. It could be from one nostril, it could be from both nostrils. Just because it's from only one nostril doesn't rule out strangles as a possibility. If we've had an abscess that's potentially just burst out into the guttural pouch of one side of the head, it may be that everything just drains down through one nostril. We can also see other abscesses in the other pictures there, just around the base of the ears. The picture in the middle is shooting up from below to show an abscess that's burst out under the jaw, and the picture in the bottom right hand side is a foal as well, with a large submandibular abscess. And here's some more. We'll this pony in the or the foal in the top right hand corner we'll see again a little bit later on in the presentation. feeling very sorry for itself. Very large abscesses that were starting to restrict the airway, and this again is reasonably common. So at this point, we may not have any nasal discharge. We may not have any other potentially open clinical signs other than a horse that's feeling sorry for itself and a big painful swelling. And I put this in as well. We're not going to talk about this. Bacillus strangles essentially is when the bacteria goes off to other more distant lymph nodes, and they can be anywhere. And the severity, or should we say, how serious that this how serious Bacillus strangles is really dictated by which lymph nodes the bacteria sequester to. And I just put it up because I wanted to show you this picture of the sort of football-sized lump behind the elbow of this horse, just how big these abscesses can become, and that is not terribly serious because actually we can create drainage in that scenario quite easily. But if we get abscesses that are internal, then actually the prognosis is significantly worse. And just as another sequel, we're not going to concentrate on this, but one of the complications that can occur from strangles is something called purpura hemorrhagica, and this is where we get little sort of immune complexes that occur as the result of having had strangles, which then get lodged in the capillary beds or in the blood vessels. They then cause the body to attack those blood vessels, creating a huge inflammatory process, and we get this edema that usually stops at about the level of the heart, and in severe cases that can cause skin sloughing, and actually that can be fatal for horses as well. Purpura and Bacillus strangles are reported to be approximately 10% of cases will go on to develop that. In my experience, and in 25 years, I would argue that, and having seen quite a lot of strangles in my time, I would argue that the incidence of that is quite a lot less. But it is a possibility, and it can occur. So we need to ask ourselves, how is it spread? Now, we're remembering this is a bacterial disease, which means we don't have to worry too much about lots of airborne spread. It's going to go from nose to nose. We've got horse to horse spread, and this is direct contact. One horse right next door to another, grooming in the stable next to it, or out in the field, grooming in the same area, sorry, grazing in the same area, or just these horses that are touching noses, and we're passing these bacteria from one horse to the next. And again, this I'm just going to repeat that's where this issue of the carrier animals, which will be potentially showing no clinical signs, may be more important in regards to the spread of strangles than active cases where they've got discharging abscesses and things like that. Because again, we're usually aware of those scenarios and we're trying to isolate those horses. So it's these carrier animals that make us more concerned about it. And then we've got the indirect contact, and essentially that's everything else. That's us as people going from one horse to the next, especially if we own more than one horse. Maybe that can be on our hands, and we can transfer it on our feet from stable to stable, on our clothes. It might be that for some reason, or you've got more than one horse and you're using hay net for one horse, and or you're mixing hay nets each night, so you're not necessarily getting the same hay net in the same stable each night. Water troughs in fields, or shared water troughs between two fields, that kind of thing. I think that's a really common way of spreading the disease. And then I also include vets and vets equipment and the farrier's belt here. I think us as professionals, we need to lead the way in terms of biosecurity. We need to lead by example. But I do think that we have that potential to be that risk of transferring the disease. I always joke that I think that the back of the farrier's belt must be the just hooching with things that have the potential to be passed on to the next horse as the horse turns around to bite the farrier's backside. And I think that vets, we have a huge responsibility as well with regards to this kind of thing, to make sure that if we're seeing cases that we think may be suspicious, that we're then taking the right appropriate biosecurity. I think if we're not, then that's not good enough. And then I put in the bottom there cats and dogs, and it is real. I've been to cases in the past and outbreaks in the past where you're dealing with a situation, and then the yard dog wanders past and looks up and gets petted and so on, or the cat jumps up onto the stable door, sort of looking all nonchalant. They do have the potential to spread things as well. Remember, it's a bacterial disease, but it is highly, highly contagious, and it doesn't take enormous amounts of the bacteria to create clinical disease. They say that about 10,000 units of the bacteria is sufficient to cause disease in a immunocompetent horse. I think that's probably even less, and they have shown it could be as little as 1,000 bacterial units in animals that are maybe immunocompromised. So yeah, it's spread there pretty much directly or indirectly, usually on us or from horse to horse. So it's worth thinking then about bacterial survival. There you go. Sorry, everyone. I'm supposed to do that from the very start. I'm not going to go back and re-record it unless anyone wants me to start from the beginning again. Right. So optimum conditions. Yeah, warm and wet conditions. And I think that maybe in the shade, I think is probably really important there. So 34 days, I think people have described even longer than that, but I suspect probably 3 weeks, maybe about right in normal soil conditions. In direct sunlight, in really dry conditions, yeah, less than 24 hours. It doesn't cope well with UV light, and the bacteria dies very quickly. And in water drinkers, I think this is the most important thing. Water drinkers or shared troughs out with adjoining fields, 4 to 6 weeks it can survive in. And that's a concern. And it's going to be even more of a concern to you when we talk in a minute about the incubation period. Okay. And just one final thing, which has some bearing on when we're taking samples and swabs and stuff like that. The bacteria doesn't do well. It's very easily outcompeted by other environmental bacteria. And when I say environmental bacteria, what I'm really meaning is bacteria that are also normal commensal bacteria in the horse. So it doesn't cope well in competition. So that is another sort of benefit ultimately that we're relying on a little bit, but equally it can be a real hindrance to us when we're trying to identify the disease, when we're trying to diagnose it, because there is the potential for us to miss it because it gets outcompeted by other bacteria. So it may not necessarily show up on the swabs that we're taking. So here's a bit of a slide which I'm going to talk you through. It's not as complicated as it. Well, hopefully it's not complicated, but. So let's start at the infection stage. Horses get infected. They come into contact with the bacteria. And then, again, one of the most important things that I want to take away from you to take away from this meeting is this idea of the incubation period, of how long it takes for that bacteria to start causing clinical signs in the horse. And that can be really quick. And I think if we have a much bigger dose of infection, of exposure, then the incubation time will go down and the severity of the clinical signs will go up. All right. But if we get a very small amount of exposure, maybe, let's say, for example, from a carrier status animal that's only shedding intermittently and not shedding huge volumes of the bacteria, then maybe our incubation period is going to go up. And I know for a fact that we've had at the sanctuary, we've had cases where we've almost been caught out, and this is long ago before we instigated the gold standard procedure that we have here now of guttural pouch washing everything. But we had horses that were then developing signs 3 weeks later plus. And the literature just does say that it can be even longer. It can be up to 4 weeks. So just remember that we've had a horse that's been exposed. Maybe you've taken it out to a show and we were silly enough to share some communal drinking water, and there was a bit of bacteria there. And then you bring that horse back to the yard, and 3 weeks go by before it starts showing any clinical signs. Just remember that, because that's part of the frustration of trying to treat this disease. So what happens? The bacteria goes essentially up into the nose. It attaches and penetrates the sort of lymphoid tissue in the nasopharynx. And often within a couple of hours, that bacteria is not detectable on the mucosal surface. So if you tried swabbing a horse, for example, at that point, you wouldn't pick up the bacteria. It can very quickly then make its way to the lymph nodes. But what we get is very quickly is we get a temperature. And again, that's the second most important thing, which is why it's got these asterisks next to it. We get a temperature, and that will go up often several days, 2 to 3 days before they may start showing any other clinical signs, before they start getting any kind of lymph node being swollen, before any snotty nose develops. And that's what we're going to rely on in early identification of cases later. All right. So it goes into the lymph nodes. The bacteria is quite good at impeding the way that the white blood cells do their job. The consequence is that the body sends more white blood cells there, and the lymph nodes then become abscessated. They become big and inflamed and swollen, and then eventually they rupture. And they, as we've seen in the pictures earlier, they may rupture externally, so they rupture through the skin, or they may rupture internally, usually through the base of the guttural pouch. Okay, so we then may get the snotty nose, and what I will say, I didn't explain this rhinitis and pharyngitis bit here. Just at the start, what sometimes you get in the very early stages, you get a watery nasal discharge. And then very quickly it will turn into a more thick, purulent nasal discharge, like we're more used to seeing, like those pictures have shown. So our abscess forms, they rupture, and then we start shedding lots more of the bacteria at that point. Now, importantly, when they've got this temperature, they're not shedding the bacteria. Okay, so if we want to control the disease, and we identify that horse has got a temperature, and we can isolate that horse quickly, we can potentially stop it from then infecting any other horses. All right. So I've said to here we've got some complications. Bastard strangles, purpura may be complications, and it's certainly a possibility. And then what happens? Well, eventually the clinical signs stop. And how long does that take? Well, it can take weeks and weeks and weeks. I've written in here, they may have lymph node abscessation or a snotty nose. These things pretty much happen about the same time, but they may have that for 2 to 3 weeks. I have had horses before now that have ruptured an abscess, and then we think, excellent, great, it's ruptured and it's draining, and then it heals up, and we think, excellent, that's the end of it. And then 2 or 3 weeks later, another abscess ruptures, and that's really soul destroying. And because you think that you're almost through it, and then straight away you get put back by another week, 2, 3 weeks, or what have you. But hopefully, the horses eventually stop showing clinical signs, and they report about 75% of those horses then become immune. The issue with that ultimately is that immunity isn't lifelong. It does wane over time, especially if there's no re-exposure. We don't know exactly how long it takes for that immunity to wane, and it probably, again, reinfection will be dictated by what the exposure is next time, the dose that horses are getting. But the worrying thing about that is that 25% of horses potentially develop no immunity to having had the disease. And I mean, I don't know about you, but that worries me because you just think, well, that they go through that horrible thing and then potentially not going to be in a position to defend against it again. So, but my strong suspicion is that those 25% are maybe the ones that have a milder form anyway, potentially. So then what happens? Well, either they um, get over it completely. They have no further signs, they're not contagious, and they can go on and live their life. Or the other option is that they become a carrier status animal. And there are two types of carriers. We've got our short term carrier, where they may have pus in the guttural pouches because of an abscess that's ruptured up into there. Or they may have bacteria that's just continuing to live in there. And they do say that that can be anything up to 4 to 6 weeks after they stop showing clinical signs. All right. And the hope is that the most of those then just continue to drain and all of the pus drains out, and then they go on to be normal, healthy animals. And again, we'll talk about this a little bit later in terms of how we identify carrier status animals and when we do that diagnostic work. And then a few animals go on to become long-term carriers, and this is when the pus either just continues as liquid pus somewhat because we can't get drainage from the guttural pouch, or it dehydrates slightly and becomes these chondroids that you may have heard of, which are these solidified balls of pus. And these animals can then go on to be carrier status animals for months to years. And there isn't much data on how long an animal can potentially go on and still be shed the bacteria, but it can be measured in years. Okay, and that's a worry. Now they don't continue to shed the bacteria on a consistent basis. They do it really intermittently, and that's the same with the short-term carriers. And that poses some problems as well in terms of trying to identify which animals might be carriers. Often they'll do it if there is some other challenge or something that gives them a dig in their immunity. And I think that often probably what's happening is that they become slightly immunocompromised because of something else, and the consequence is that they're not able to keep on top of the strangles, and then they start shedding again. Alternatively, it's just that the bacteria in the guttural pouch then become available through movement or whatever, and they and are discharged through mucus secretions back into the nasopharynx and out through the nose. Right. How do we diagnose it? Well, it's not that hard usually on clinical signs, but just remember what I said earlier. Some of them have nothing more than just a snotty nose. All right. So that's a bit scary to do that. But I think by the time they start developing abscesses, then the likelihood is that this is strangles. There are other things that theoretically can cause strangles. Streptococcus zooepidemicus, which is incredibly similar bacteria. It contains something like 97% of the same genealogy as Strep equi. That can, in rare cases, also cause abscessation, but the honest truth is because that can also be really really contagious. It's actually academic because you probably ought to be treating them in the same way as well. But so what do we do? How do we diagnose it? Well, how we do and when we take swabs and when we take samples is really important because the time scale between being exposed, incubating, and then showing clinical signs can be quite a long time. And if we try and swab these animals, for example, stick a swab up the nose, then there's a really good possibility we're going to get a negative result from it. So PCR, I've put up here, PCR is polymerase chain reaction, which it's ultimately it's looking for the DNA of the bacteria. And it's very sensitive and it can pick up very small numbers of bacteria and even fragments of dead bacteria. but if we haven't got to the stage where an abscess has burst or we've got developed that snotty nose, then we may miss it. So I think it's really important that we time our swabs really carefully. And what can we do? We can yes, if we've got a snotty nose, then actually the most effective thing, bar none, would be a nasopharyngeal swab. And it's actually better. It's proven that it's better that you put one of these swabs that goes all the way up the nose, right to the nasopharynx, and then back out again. Horses hate it. Occasionally, you have to sedate them to do that, but we try not to, especially if they're still running any kind of temperature. We can stick a needle straight into a swollen or abscessated lymph node and send that off again for PCR and maybe culture as well. PCR and culture are the absolute gold standard, and to do both of them gives you as greater confidence as you can possibly get. Lots of people will just do the PCR test because it makes it a little bit cheaper. It is possible, it's rare, but it is possible to get a negative PCR and a positive culture. But usually, if you've got a negative PCR, you're likely to have a negative culture as well. So that's why people tend to sometimes miss out the culture element of it. And finally, how are we going to diagnose it? Well, a guttural pouch wash. And once again, same principle. We've got an outbreak on a yard. Well, we're not going to go in straight with a guttural pouch wash to a horse that hasn't necessarily started showing any clinical signs yet, because there's every possibility that we'll get a negative result, and we could move that horse. It maybe haven't got abscesses that have burst, and we could move that horse, and then it could to a green group, and it could cause us all sorts of problems. Um, so I've also put up here blood samples, and I think we've got to be really careful. The blood sample, the serology, which we're talking about there, where we did this ELISA test, is brilliant if used in the right way. And I think that diagnosing it at the start of an outbreak is absolutely hopeless, and I don't think that you should be doing that. It will take usually at least 14 days in order for them to what we call seroconvert, kick out an immune response to the bacteria. So a negative result doesn't tell you anything. All right. But what it does do, and that's why we'll talk about it later, is it measures exposure to the bacteria. So if we were to take a sample at 14 days and it was equivocal, you're going to want to then take another sample 14 days later. And I can't help feeling that by the time you're a month down the line, the blood sample wasn't worth spending the money on. We'll use that later to see whether your horse did actually. Oh, actually, I should say donkey as well, shouldn't I? Because I've just seen that you guys are there as well. Um, but we would, yeah. We'll use it to see whether these animals were exposed to the bacteria, because if they were and they kicked out an immune response, then it's really useful. So here's our carrier animals. We can skip through this bit. Short term, where they may only shed for a few days, again, depending on how bad it was and what kind of whether they got big discharge into the guttural pouch, or anything up to 4 to 6 weeks after they stop showing clinical signs. And even then, they can get rid of all of the pus, but we do think that there is that potential for them to the bacteria to still live in this sort of invisible biofilm in the pouch as well. But that again falls into potentially this long-term carrier scenario. And these are just two little pictures that you can hopefully see down here. So these are chondroids at the bottom here. And I'm so sorry, because I've got some wonderful pictures and videos of, or have seen some wonderful things. But always forget to take pictures, or now store them on my computer. So now, can I find the memory stick where these pictures are? No chance. But anyway, that is what chondroids look like in as dehydrated these balls of pus in the bottom of the pouch. And this is the pouch here where we've got a discharging abscess as well. So empyema just means liquid pus in the thing as well. So how do we diagnose these carrier status animals? Well, as we've just said, the blood sample. Now, it's not reliable. The blood sample is not reliable for detecting carrier status animals. Okay? It can be used and it can pick up carriers. The problem is its specificity and sensitivity, positives being positive, negatives being negative, is not brilliant. Okay, so the consequence is we could get false negatives from it, and I think that's really dangerous. So it's another of these limitations where good livery yards are now being switched on, and they're saying we want you to do some testing before you bring your horse to us. And they're saying, we want you to do a blood sample for strangles. And I'm still all for it because what it's going to show is have we had recent exposure to it? And if we have, then they can potentially do something about that before the horse comes. So it will pick up horses that have had recent exposure to strangles. But it may well miss those that are carrier status animals. So the only reliable way of diagnosing carriers is through a guttural pouch wash. Okay, and this is where we'll take a wash, which I'm going to show you how we do it in a second. Um, and we then send the samples off for PCR and culture and find out what's going on. But usually, hopefully, you look in the pouch and you can usually tell when they've had inflammation in there and when they haven't. And I'm going to show you a picture of that again in a second. You can do 3 nasopharyngeal swabs, and as soon as you've got one negative, then you can go back and take the next. And then as soon as you've got 3, theoretically, that's supposed to give you an 85% confidence of a negative value. But the honest truth is, I don't think it does. And the intermittent shedding nature of it means that you can go through the cost of all of that and they can still become positive on the 3rd swab, by which point you've had 3 visits from the vet, 3 swabs taken, 3 lab fees. You're already probably in excess of what you would have paid for a guttural pouch wash. So I personally don't use nasopharyngeal swabs to try and diagnose carrier animals. I think that as soon as you've got any kind of positive, then you're looking in the guttural pouch with a endoscopy anyway. So I don't use it. And here we go. You can tell how old this picture is, partly because I'm looking down the scope, um, and also because I've got more hair there. And I didn't point it out earlier, but Charlie's got this ridiculous like influencer's light on me at the minute, which I'd really like to show you. But all I can do is every so often I keep getting this glint off my head here where I'm clearly so much balder than I was 10 years ago. So anyway, that's not really the point of that picture, but yeah, I would no moustache here as well. You can't tell because it's all covered up, but no moustache there. So yeah, it is a long time ago. So here's the back of the horse's nose. We've put the camera up, and again, I'm sorry that this I've got some much nicer pictures than this somewhere because this is on my old scope, so the picture and the color isn't great. But these 2 white lines are the ostia that go into each guttural pouch. So we're looking up, and this is the horse's right guttural pouch. This is the horse's left guttural pouch. Just behind this little indentation here is the horse's brain. It's probably about the same size as that, actually. And just down here is the larynx, which just out of view, which we can't see. So let's just go to our next thing. I'm going to show you a video, and we'll let it run. And this is us getting into the pouch. So again, this is a very old video because I would have hoped to have gone poop straight in. So it shows a much more inexperienced technique. Let's pretend it was one of my other vets that was doing this. Right, so we go in. We have to use a guide wire to open the ostia because they are usually closed until they swallow, and when they swallow, they open like that and then they shut again. Right, so then we turn it round. We're using this guide wire to sort of almost lever it open. We're completely upside down at this point, and there you can see we've got this little closed off avenue that we're going to go into. We're upside down, and we are in. And then we're going to turn the right way up. And again, I'm really sorry because the picture doesn't do it justice. Our new machine is so much nicer. Yeah, that's the external carotid there. The internal carotid just missed it just at the top up there. And this is the floor of the guttural pouch. And remember that because that's where most of our abscesses are likely to burst up and out of. They are, I was saying, I apologize because the image isn't as good. It is a beautiful structure. Honestly, absolutely stunning structure. And if ever you are unfortunate enough to have your horse have a guttural pouch wash, take some enjoyment at the very least from just how beautiful the inside of their heads are. They look like the ceiling of a cathedral. It's phenomenal. But they also contain these, let's see if I can just bring it back, these pretty exciting structures. So, it probably doesn't need spelling out that if you prang the carotid too hard, that's going to cause problems. So this pouch is split into two halves. This is the main part of the screen now is the medial compartment, and then some of these again I'm pointing with my finger, realizing you can't see, but I think if I let oh no I can use my mouse now. Then we've got some cranial nerves that come down here as well, and the cranial nerves are really important nerves that carry out very specific functions, and that's why strangles causing problems or getting big buildup of pus in there can cause problems, and why the treatment of it can cause problems as well. And then we have the stylohyoid bone that sort of runs down the side of the pouch, and then we have the lateral compartment just here. But it's this bottom of the pouch here where usually we're looking for things. We're looking for pus, we're looking for chondroids, we're looking for evidence of something having ruptured out. So let's go on. Here is an example, and I wanted to put this in there just to point out some of those. And this is the other way round now. So this picture on the left here is the other pouch. So this would be the horse's left pouch. But I wanted to just point out the nodules that you can see all in there. And this is a pouch when they've taken wasn't me that took this picture. That is a pouch that has had something go in it because there's this lymphoid hyperplasia, this reactive tissue in there. So it has been responding to it. And then this picture just over the top right, again, doesn't do it justice, but it's a beautiful structure. And then this bottom right-hand corner is the using a different type of guide wire biopsy tool, which is sometimes necessary to open the ostia because it can be quite troublesome. And here we go. So if we took a top left-hand picture, the top of the pouch is at the top, and then we've got this large sort of golf ball size structure here with pus literally oozing out of the top of it, cascading down. Bottom left-hand picture, this is an abscess that's just on its final throes of trying to discharge. And then another one on the right here. This one was, I remember this, it was a lot harder to, because the one top left is obvious. You've got a nice big round, obviously abscessated structure. The one here, it just felt a little bit like the floor of the guttural pouch was raised. But lo and behold, we're draining pus into here. And you've just got to let that run its course. So very quickly, really conscious of time, you're sure you're all desperate to go to bed, but this is a view of a chondroid in a guttural pouch that we've now filled the guttural pouch with water because we are trying to flush this out. We're trying to get rid of it. Now, we're not going to get them out just by flushing. We're trying to dislodge them so that I can then get a little basket tool that goes in, grabs them, slices through it, breaks it up, and then we can try and flush it out. Smaller chondroids, or when they are drier and they're more solid, you can actually grab them with that tool and pull them out. And get rid of them. But I just thought it was quite nice. So we're at the minute we're down, and you're looking at underneath the water, like you're in a swimming pool looking up at the water above you, and that's where we are. So you can see the bubbles rising. So I'll just very quickly play it again. So yeah, top is up this top right hand corner, bottom is bottom left, and these are big chunks of pus essentially swimming around. And I will say, people often ask me, "What's my favourite thing? What do you like more than anything?" It's fishing these out of guttural pouches is, I'm sure, my favourite thing to do in veterinary medicine. I must remember that when people ask me again in the future. But it's really really challenging. But I just thought it was quite interesting, and I finally remembered to press play or record on that video. So what are we going to do with regards to treatment? More often than not, we're going to let it run its course. Okay. And that is usually what we will do because the vast majority of cases will get over this without too much intervention. All right. In terms of the serious bit where they're feeling pretty poorly, what we'll relatively regularly do is give them something to make them feel better. Okay, so we'll give them some non-steroidal drugs, and we have to think about how we're giving that because obviously, if they've got really bad and they can't swallow, then we need to maybe give them something IV, or we may have to take a different approach. But we're going to give them anti-inflammatories to make them feel better. We might try and poultice the abscesses. We might try and get them to brew up and burst out quicker. And we can lance them, which I'm going to show you a picture of in a minute. Then it's supportive care. We're going to give them soft, palatable food. We're going to lift water buckets and feeds to just try and make life easier for them. We're going to give them TLC, all right? And are we going to use antibiotics? Oh, almost never. Okay, so you have the potential to use them before abscess formation, but abscesses can form really quickly, so I think it's really risky. You run the risk of prolonging abscess development. So you give the antibiotics and then you stop, and then the abscesses develop anyway. There is also an argument to say that they can suppress the immune response that the horse produces, and which ultimately then leads to a decreased immunity to potential reinfection. So we might use it in emergency cases where we're getting to the point where they can't breathe, they can't swallow, where the true strangles nature comes into it, or horses where they've got this persistent temperature and they just feel awful. All right. So, and then I've just put at the bottom here, early flushing of the pouches. I've got to say, I mean, this is amazing if we need to do it, but we never do because it costs too much money to do it. But but what you can do is if you flush early, then you can avoid that scenario where you saw everything swirling round because you're flushing out liquid pus, and that's a lot easier. But the problem is it costs money to do that, and there's no point going in and doing that, and then because you're not going to take samples because we know it's strangles at that point. So, and if you go in and you flush it all out, and then you see that you've got a discharging tract, then actually you're flushed, and you're like, well, it's still going to fill up with pus again. But there are circumstances where it would be quite useful to ultimately to flush out some of that pus to make our life easier at a later date. And here we go. This is treating with antibiotics up the nose. I haven't got a picture inside the head, but this is a mixture that we use to go up, and this is it's an AI catheter that I've bent at the end slightly, and it's going into that ostia, and then we're pushing it in, and because it's in this gel form, it stays in there. And we would only use that once we've treated a known case, a known positive case. I wouldn't use antibiotics in that scenario unless I'd got a positive sample from a guttural pouch wash previously. Again, no moustache, lots more hair. Gormless look remains the same. And here we go. Very quickly, lancing an abscess. And this again, I've got permission it's 15 years old permission to use this, or 10, 12 years old permission to use it. But this was a pony at the sanctuary before Beech Trees and the biosecurity unit was built. And they had a huge outbreak, which was actually what then prompted the building of the amazing Beech Trees facilities, which we're in at the minute. And this is a foal who was then starting to struggle to breathe. And we surgically prepped it, local anaesthetic, cut down, and oh my God, I was sweating that day. Because this is the jugular furrow that runs up here, and I'm cutting into tissue. I've got no idea what's going on here. I can't remember whether we scanned this beforehand to be less brave, but and then you can just see in the bottom right hand corner small amounts of pus. Okay, now that is all that we got. We got so little pus out of this big swollen lymph node. I was really disappointed because I was really hoping it was going to be one like that. You make a cut and it just goes like the most satisfying pimple popping video ever, but it wasn't. It was really disappointing. But the next day after having done that pony was so much better straight away. Massive improvement. So we did it because it was important, and we were having a big problem at the time, and this pony was in a bad way. The foal was in a bad way. So what are you going to do on your yard? Are you going to try and prevent strangles, or are you going to try and control it when it occurs? It'd be lovely if we could all prevent it, but the honest truth is I do realise that we're very frequently going to fall into the control program where we're just trying to pick up the pieces. But if we go for a prevention scenario, we're really thinking about a zero tolerance to it. And that means that we're going to isolate all of our horses for 3 weeks, new arrivals for 3 weeks. And as we've seen, is that going to pick up all of the ones? If they came on a transporter and they got it on the transport lorry, is it going to pick them up? Well, it might not, had it? And if you're on a yard and they have a 2 week isolation or quarantine period, what do you think of that? That's worth speaking to the owner about, isn't it? And I'm more than happy I will say, and I'm more than happy to have open and happy discussions with anyone who wants me to speak with owners and stuff like that. If the owner is interested and wants to, if I'm not their vet, they may not want to, or they may speak to their own vet. And how many people are on a yard where horses are guttural pouch washed or blood sample and potentially guttural pouch washed before they're allowed entry? Well, almost none. Though we have got a person down here at the minute who sells horses who is doing exactly this, and he's trying to get owners to do guttural pouch washes before they go. There is a limitation to that again. If they have been recently exposed, it could give a false negative. Then blood sampling to identify horses that are coming on again. Yeah, maybe we'll miss the carriers if we get some positive results on the serology. Maybe we'll do a guttural pouch wash on them, and that's a good idea. How else are we going to prevent it? Well, again, you don't need me to read it, but individual equipment. You don't share stuff between horses. You don't share tack equipment, grooming kit, hay nets. Theoretically, wheelbarrows, brushes, brooms, shovels, whatever. So we're thinking about having good, stable, and yard hygiene. Just being sensible, not going around and stroking other people's horses or messing with other people's horses unless asked to. And then having these clear guidelines that everyone sticks to. And I think that 100% compliance point is the most important part, is that everyone needs to be on board and everyone needs to be heard and everyone needs to be able to give their voice about what they think, is doable and not doable, and whether they can cope with that. But everyone needs to stick to it. Everyone needs to agree to it and stick to it. And then I suppose if you agree with something, then it can be put down in writing, and all new people who are coming onto the yard do so, and they are expected to abide by those rules of the yard. And vaccination we're going to come on to later, because this is somewhat of a game changer now. I'll talk about that later. But vaccination, if you're going to prevent strangles from coming on your yard, well, obviously vaccination itself doesn't prevent them from getting the disease, but it massively reduces their clinical signs and the potential for them to develop abscesses and things like that. So, and what is definitely true is that, hold on, I better row back on that. What's likely is that prevention is going to be far more cost effective than treating an outbreak. Okay, because if you get an outbreak and you're going to treat it properly, it's going to cost you a hell of a lot more. I guess there is an argument. It's like insurance, isn't it? You may never need it. But depending on what type of yard you're on, yeah, if they're vaccinated, then that may well pay off. So some other quick rules. You're going after your horse is leaving the yard. You are taking your own water and drinking and buckets. Okay, you are never using I mean, I'm not worried about tap, obviously, at somewhere else's place, but you're never using the troughs to scoop water out and stuff like that. And you're never using anybody else's stuff, and that includes people, I think, that you're going to events with from the same yard potentially. You're going to be sensible about what you're doing with your horses. You've taken your horse to camp, but you're not going to stand around when you're in between bits where you're allowing horses to put nose-to-nose contact and squealing at each other. It's just, don't do it. It's easy to not do it, so don't do it. If you want to be really sensible, you only handle your own horse, and then if you do have to handle somebody else's horse, then you've got wipes. The bacteria I meant to say earlier is really sensitive to disinfectant and stuff like that. It doesn't, it's killed very easily ultimately. So yeah, wipes, wash your hands, soap and water, wipes, and you should, with disinfectant wipes, you should be fine. And then, yeah, don't allow your horse to go down and graze where other horses have been grazing. So what are we going to do if we've had an outbreak or we suspect an outbreak? You're going to isolate those horses as quickly as you can, and you're going to put as much distance between them as other horses as possible. This is where you need someone taking control. We're going to talk about that again in a second, but you need you need everyone to be sensible, so those horses to be isolated, people to be honest ultimately, and any sort of direct in contacts are going to be put into their own group as well. We'll talk about that in a second. And I think if you suspect strangles, you should be closing your yard and you should already be thinking about no other internal movements. You're trying to limit how much you can then potentially spread this to other people, other horses on the yard. And then we're going to monitor rectal temperatures twice a day. Remember that pyrexia, that fever that they get, happens at the very start. Okay, and they are not shedding at that point. So we can move horses that we aren't worried about at that point straight to the red group if they spike a temperature. And if we're doing it twice a day, we're going to pick that up and we're going to pick it up before they become contagious to the horses that they've been with and around. And then I think it would be, you're suspecting what's going on. I think it's sensible to call the vet. Not necessarily saying the vet has to come out at that point, but we could give you some advice. You know, we could tell you what to do and how to try and manage the situation, especially if it's a yard that we do most of the work on. So we've confirmed our outbreak. We've swabbed our first animal, or we've made the positive diagnosis, and we're isolating the horses. We're putting the infected horses into the red group. We've got the purple amber group here. I had to write it in purple, obviously, because I tried to write in amber and then you couldn't read it. It didn't show up. Those are in contact animals. Okay, so they're the ones we're most worried about that may develop signs. And then we've got our green animals, and you've got to hope that this forms the bulk of your horse population on the yard. But you are taking the temperatures of both that amber and green yard twice a day. And then we're instigating our strict biosecurity, and we are being as sensible as we possibly can here. And again, I think it comes on in a second where we're going to talk about that more. And horses can then only move back to a green group once we've proven after they've been, if they're positive, if they've been positive, when we've proven that they are no longer infectious horses, they are no longer carrier status animals. So, and remember the timescales I've been giving. Incubation can be anything up to 3 or 4 weeks, and then clinical signs may go on for 2 or 3 weeks, maybe longer, and then testing process is going to happen 6 weeks or so after they stop showing clinical signs. So that is a long time that horses have been in this. This is why I said at the very start, it's frustrating to treat, it's frustrating to deal with, and that's why compliance isn't often brilliant. And here we go, communication. Um, I wrote some stuff down here because I knew I wouldn't remember it all, so I'm going to read some of this off. But I think at this point you've got a positive thing. You need a yard meeting. Everyone's invited to it. It doesn't have to be in person, and probably better that it's not at the yard. But look how easy it is to do a Zoom meeting or a WhatsApp meeting and get everyone together. I think that you have to get everyone together. You need to outline the situation on the yard. There needs to be open and honest communication about everything, not trying to hide anything, not trying to hide the fact that, oh God, we may have strangles on the yard. Don't tell anyone. We're open and honest about it. If we did that, then there would be significantly less spread of the disease. So outline the situation on the yard. I think that one person needs to be allocated to manage the yard outbreak and by that I don't mean the vet. I do think there needs to be one vet in charge, especially if it's multiple practices that are going. And those vets from multiple practices should talk to each other and agree on the treatment plan and what's the right thing. Probably doing that in conjunction with the person who owns the yard as well, so that they know, or that person who's going to manage the outbreak. You're going to agree your treatment strategies. Agree your biosecurity measures, agree your exit strategy, how you're going to get horses out of this situation as well. You're going to be advising everyone taking temperatures, monitoring for 38.5 degrees. You're going to be talking to surrounding yards and just giving them the heads up, giving them the opportunity to put their own biosecurity into place. Give them a chance to prevent it getting onto their yard. Call the vets and farriers and people that come on, and that's going to be the individual's horse owner's responsibility to do that, to let people know that that's going on, so that they don't walk into a situation that they're not aware of. You're going to think about. Sorry, bear with me. Just going to very quickly check with the next. Yeah, okay. You're going to disinfect your water troughs. You're going to think about emptying them, cleaning them, drying them, disinfecting them. Don't just add disinfectant to the water. Obviously, that's not safe for the horse, and it is not effective against killing the bacteria either. You're going to put as much distance as you can. I think I said between groups. Increasing the distance decreases the transmission of the disease, and we're looking at sort of a minimum of about 3 meters or so, just to try and stop that nose-to-nose contact. You could consider, depending on what your yard is like, you could consider creating a scenario where all the horses are turned out. Not brilliant at this time of the year, I appreciate, but in the summer, that'd be phenomenal. We've heard that it doesn't survive well in bright sunlight. It decreases the need for mucking out, it decreases the need for human intervention, decreases survival of the bacteria. Um, it's a sensible option, and you don't have to keep going in and feeding them potentially. I guess those horses that are in the green or amber group, we've got to go in and we've got to take temperatures, but turning out or keeping them turned out may be a sensible option. And then maybe it's only the horses that are in the red group come in. Um, you're going to stick to your own horse. You're going to wear PPE, gloves. You're going to have sensible ways of disposing of those gloves. Speak to your vet about that. They can give you clinical waste bags. Hopefully, there's going to be a hand washing facility area, and you're going to disinfect that hand washing area regularly. Maybe you wash your hands, wash them up, and then you disinfect that area as well. And then, using a wipe, you disinfect the spray bottle so that isn't the fomite for it as well. I think you get the idea. But the final thing I wrote down was you're going to support each other. Okay, you're going to help each other, and rather than pointing the finger, saying, "Oh, he brought it on, she brought it on, that's the horse, that's the one," because we don't know because of this carrier status. So sometimes the finger gets pointed at the horse that develops signs first, and that's not fair because the likelihood is that they've picked it up from somewhere else, or they picked it up on their way, to the new yard. So what happens next? Well, it can take weeks to months, as we've described, that the disease takes to run its course, which is why it's such a debilitating disease for yards. And really, if we can identify the outbreak, the cause of the outbreak, that would be ideal. All right. I am old enough and grey enough, well, kind of grey enough to realize that this is the reason why the disease is still here, because it's expensive to do, and you're setting yourself up for some big costs to do the guttural pouch wash to prove that your horse is no longer infectious to others. If we could get everybody to do that, then the whole disease process would be a lot easier and quicker. Um, so yeah, confirming that the individuals are clear by guttural pouch washes. And this is where blood samples are really useful. You've got that green group. This is where we might blood sample those. If we want to open a yard up, we might blood sample those. And if they've got really low antigen A and C and that serology, we know they haven't been exposed. They're good to go. They can move wherever they want to go. But really, that yard should remain closed until we're confident that we've got no more, until all horses are negative. So the last little bit that we're going to talk about, I promise you, we are almost there now. You can all breathe somewhat of a sigh of relief. I'm sure you're all desperate for the toilet, or desperate to go to bed. We've got vaccination, and this is a game changer. And the reason why we are really getting behind this one now is because the vaccine that we've got now, which has been on the market for a little while, but is a novel approach to it. That the previous vaccines used different proteins. They had massive limitations. Not least one of them was that you had to give it in the top lip of, or one of them you had to give in the top lip, the mucosa of the lip. That particular one used live attenuated bacteria. There were arguments that the vaccine itself potentially was the cause of other outbreaks. Whether that's actually right or not, I don't know. But it was not a nice thing to do. Um, and the new bacteria is the new vaccine is intramuscular, so it's much more easily given. It uses these 7 novel proteins that come from a strain of bacteria that was, I can't remember when it was isolated, but it's those 7 proteins are common to all strains of the bacteria. Those again, the proteins that they use are not restricted by the potential for mutation of the bacteria as well, which is a problem that happened with the SEM protein that they used for previous vaccines. And finally, it doesn't use any of the proteins that we use for the serology, and it doesn't interfere with the results we would get from guttural pouch wash results as well. The only thing is you're going to use that on healthy horses. It's not ideal in the face of an outbreak because you've got to give two injections a month apart, and it's only 2 weeks after the second injection that they are really they have sufficient immunity. Now, it might be that if you're a horse in a green group and you can look into the distance and realize that this outbreak on your yard is going to take a long time to shift. You know what? I potentially, if you can guarantee that your horse has definitely had no contact, then I would be thinking that potentially there is an argument to vaccinating in the face of the outbreak there if you can continue to keep that horse safely in that green group. And then the one thing that the vaccine manufacturers do suggest is that depending on the risk, that you repeat that vaccine every 2 months. And I can't see everyone's screen, and I can't see. I could ask for a show of hands who is likely to get me to come out and vaccinate the horse against Strangles every 2 months, and not many of you are going to be raising your hands. Um, from a practical point of view, what's been sort of agreed amongst the experts is that it can be a much more sensible approach. Interestingly and really usefully, immunity is still maintained for 12 months after the primary course. After that 12 months, it really drops off, and you go much more than 12 months, you ought to be thinking about restarting your course again. But you can boost again at 12 months, and your immunity will go straight back to where it was. If you are on a high risk yard, lots of movement horses coming in and out, you would go eventing where you take your horses off left, right, and centre. 6 monthly would be really sensible. And again, if you're in a high risk yard, 6 monthly would be sensible. But again, what you might consider doing is doing the 12-month booster. And then if you're on a yard where there's the potential for, or someone suddenly identifies an outbreak nearby, quickly getting us in and giving a booster vaccination. So what does the vaccination do? As I said to you earlier, it doesn't stop clinical signs, okay? As in, it doesn't stop them getting the disease, but it helps them produce a better immune response to it. And the consequence is that they don't tend to form abscesses, they get a much quicker recovery from it, and they don't shed the bacteria in the same way. So the risk of transmitting it to other horses is massively reduced as well. I need to give you informed consent when we're doing this kind of thing. You need to know what those potential risks are. The good news is this vaccine doesn't contain any live bacteria. You are not putting anything into that horse which is going to give it strangles. Like I said, it's just fragments of these proteins that we're using. The side effects that we see, they report it to be about 5.6% of horses um, that are vaccinated could create have side effects. I think actually, truthfully, the result the side effects are probably higher than that. There's probably 20-25% of horses might show a one or more of the signs that we're seeing, and they may have a transient temperature that may go up as they kick out an immune response to this challenge, and that can last from 1 to 5 days. They can get a little bit of localized swelling and muscle stiffness, and they can be a bit lethargic and sort of reduced appetite. In all cases that were reported of this previously, all horses responded within a week without any veterinary intervention. I have spoken to other people, other vets that use the vaccine, and they've said if they get any of these signs, they give a little bit of non-steroidal at that point, and the horse makes a rapid recovery. In general, we're not giving it at the same time as the vaccine because we don't want to interfere with any kind of immune response to the vaccine itself. So it's only if we're getting any side effects. And there's the final push, just to let you make sure that you are aware of the vaccination amnesty. Frustratingly, with this, we tried to push them on this to get them to extend it, but all practice they will only open it for a 1 month process, DECRA. But it's very good of them to do it. So as long as you get your first vaccine in before the 31st of December, then you can have your second vaccine 4 weeks later, and then the third booster will be free of charge. Okay, so yeah, whether you give that at 6 months or 12 months or what have you, you still have to pay the visit fee. But if you can get other people on the yard, then that to doing it, then that cuts that cost as well. So there you go. Wow, I've talked at you for an awfully long time there, and I hope it was all not too waffled and not too speedy. I'm going to open it up to questions. Now, I don't think I said at the start again because I was getting all flustered for you to type your questions into the chat. Now, what I will say is that because I didn't say that, or I can't remember saying that, if you've got any questions and you want to ask them now and you want to unmute yourself and you want to ask it directly, then let's hope I know the answer and I'll do my best to answer it. If you want to type it into the chat and you don't want to appear on screen or you don't want to say it out loud, then do type it into the chat. And if there's no one got any questions, it means I've explained everything so well that there is no space anywhere for any question because all questions have already been preemptively answered. That's what I've done, isn't it?
Could I ask one question?
Oh, Jacqueline!
But I have to say, although I haven't got a yard or anything, I found it absolutely fascinating, and I don't think you should do yourself down. I found it very, very interesting.
Good.
But could I just say, I've read that just for anyone who's watching, we've got 2 donkeys, and I've read that donkeys aren't as prone to strangles as horses. Have you ever known donkeys or a donkey to have strangles?
So I think the answer to that is yes. Um, I'm trying to think. So I have to be very careful here because there's client confidentiality to a degree. But when I worked at St. David's, we did the work for the donkey sanctuary and one of the farms of the donkey sanctuary. And there were instances where we had horses donkeys, sorry, that we then had to move down into isolation. I cannot remember from my rapidly deteriorating memory of any where they got really horrible abscesses that we have in the same way as horses. I do wonder whether, from a worldwide population, whether the donkeys get it less because maybe they are more common to those arid conditions where it's less likely to survive. But the honest truth is, I hadn't heard that. But I guess if I were to think back to how many cases of strangles I've seen in donkeys, it would definitely be a lot fewer. But then equally, the population that I look after contains significantly fewer donkeys than it does. But it's interesting. I'm not 100% sure why it would necessarily be the case. I think that, but what I will do off the back of that, I will have a chat to the people at the Donkey Sanctuary and ask them their opinion on that as well. So, and I'll put that in some kind of link once I've to the people that have turned up or that were registered. I'll put it in as a little side note. So thank you.
Thank you. That would be help me make a decision. At the moment, I'm thinking as long as we're very careful, we should be able to get away without vaccinating.
So yeah, we probably won't get too much into the ins and outs of each individual person, but I
No,
would say you where you are very low risk.
that's very reassuring.
Yeah,
Thank you very much. Thank
very
you.
low risk because of your location and your setup.
Yes.
Very low risk.
Yeah.
Right.
Okay. Thanks
So,
very much.
so I've got a couple of questions. Becky asks, how much is the vaccine? It's 55 quid per vaccine. Okay. Can it be given alongside the flu jab? That's Tori. Yeah, excellent question. Which is also asked by Karen. And the answer is yes, it can. It is not licensed for use at the same time, as in the licensing process that they went through didn't involve them also trialing that with other vaccines. But what has been done is it has been used I guess theoretically off license in that respect, alongside flu and tetanus and herpes jabs, all given at the same time. So yeah, 100% it can be given at the same time as the other vaccines. All right. Let me just have another quick look. Will this become, Lisa asks, will this become mandatory for competitions like flu and tetanus? I doubt it. I doubt it. So we're often asked, or people often make the assumption that Strangles is notifiable. It is in some other countries, but not in this country, and therefore, the control of it is not as good as it could be in other countries. Um, Speaking of which, does anyone know which country doesn't have Strangles? Quickly type it in the box if you do, in the chat. So I don't think it'll become mandatory. What might become the case is that certain events might start saying, as the vaccine becomes more popular and people start to realise the absolute benefit of it, they may want to, but I suspect they won't, because it will limit their uptake of entries, and I think that would be enough to stop them. So right, it's not New Zealand. It is Iceland, Rosie. Well done. And Karen. Yeah. Right. Sorry, Tori, I missed the start of the meeting. Is there now more of it? Hence the meeting, hence advice to consider the vaccine. I'm going to tell you now, Tori, that there is, I would argue, no more strangles around now than there was when I qualified 25 years ago. I'm hoping that our identification of it is better than it was. It's a little bit of a hot topic at the minute because there's certainly one relatively local to us, not necessarily to you, Tori, but outbreak. I would say it's endemic on the moor. For those people that live over that neck of the woods, and again, that just massive limitations on trying to control that situation. So, yeah, and maybe it should be notifiable, but I think the problem about Lisa with it being notifiable is that it suddenly adds even more cost to people. And trust me, I hear nothing about how expensive we are, so about how expensive vets are, and so it might cause a problem. I don't know what would have to happen for it to become notifiable in this country, but yeah, it's not the minute. Right. It's 25 past 8, and I'm sure you all must be losing the will to live now. So, are there any more questions before I sign off? No, and most people have got their things going. Cool. Okay. Well, thank you, everyone. Nice to see you all, and thank you all for coming. I really appreciate it, because it's these things don't just write themselves, and it's quite nice to know that you are actually talking to somebody at the other end. So thank you very much, and have a lovely Christmas, everyone. Cheers.
Thanks, Richard.
Cheers. Bye. 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 Bye.
Bye.